Welcome to the AI Revolution podcast, where we'll continue our learning series on AI in healthcare. I'm your host today, Carrie Purcell, joined by my co-authors from the AI Revolution book. I'm just showing the cover for those of you joining by video. So two of my co-authors are here with me today. One is our in-house resident healthcare expert, Jaspreet Chager, who you've already met. And today we're also joined by our guest, Dr. Glenn Loomis. I'm excited to have him here with us today as we look into AI tools in healthcare. We're going to try to differentiate the hype from the tools that can actually aid in healing today. Before I introduce our guests further, let's set the scene for the state of healthcare today. Healthcare workers are drowning in documentation. They're facing unprecedented burnout, and we're being told that AI is the solution. But this promised transformation is no small feat. A new report from Digital Health Canada shows 8 leading hospitals wrestling with this, implementing AI tools, but with very different approaches and getting very different results. So today we're going to talk to someone who's seen AI from every angle, Dr. Glenn Loomis. He is an emergency medicine physician, founder of Query Health, a medical AI agent company, and author of the American Medical Association's first white paper on AI in healthcare. And as I noted, he's also co-author on The AI Revolution, where he wrote Chapter 16 of our co-authored book, The AI Revolution in Healthcare. We're going to pull content from that today, share as much as we can with you. And Glenn, you've spent 30 years teaching medicine, leading physicians, developing healthcare technology. You've worked with the American Medical Association and the American Academy of Family Physicians. And in 2024, you founded Query Health with a bold vision to provide AI-enhanced medicine to the planet by creating an AI physician agent that automates daily physician tasks. We're going to dig into all of this further, including what led you to found Query Health now, which I think will become very clear. But before we do, I just want to thank you for taking the time to join us today.
Yeah, it's a pleasure being here, and it was great to be part of the team writing the book, and I'm excited to talk about it a little bit in a little bit more depth, or maybe add some color to some of the things that we talked about in the book.
Yeah, that's wonderful. For those who don't have the background, the AI Revolution was a collaborative effort of, I believe, 34 different authors worldwide, crossing sectors. But of course, today we're really going to dig into healthcare specifically. And people have shared a lot of expertise throughout the book, but we're also going to bring in everything we didn't get into the book, everything that's happened in the months following the publication of the book. I have Jaspreet Chager with us as well, again, one of our co-authors. And Jaspreet, welcome back. I look forward to talking about this important topic with you as well today.
Thank you, Carrie. This is such an important topic. Thank you for having me.
Good. Wonderful. So I want to start our conversation today. Again, I've tried to give a little bit of framing the problem, but I really want to leverage the expertise of our experts today. So what are the problems that you're really seeing in the field today? And Jaspreet, I'm going to let you give us a bit of an intro first.
Yeah, for sure. So, as you mentioned, Carrie, in the beginning, healthcare workers are drowning in paperwork and pressure. I saw it personally myself. I saw pharmacists completely burn out. And AI is being called that lifeboat. But is it actually keeping everyone afloat? That's really the question. Or is it just making more waves and causing more disruptions? And as we heard, Digital Health Canada has highlighted that 8 leading hospitals in Canada are dealing with this exact question, but getting very different answers. So, Glenn, from your perspective, what's the day-to-day reality for clinicians right now?
Yeah, I look at the problems in healthcare from sort of 3 perspectives, at least in the US. There's the people problem, right? We don't have enough medical assistants. We don't have enough nurses. We don't have enough doctors. And so that's problem number 1. So everybody is stretched very thin and being stressed to the max. The number 2, we have a lot of process problems in the US. I don't know in Canada if it's the same, but we, almost every process, if you look into it, isn't really designed with the right human factors and the right process factors. And so sometimes we have to rely on sort of superhuman human effort in order to get to good outcomes and make sure that, people are safe. And that's problem number 2 that I look at. And then the third problem in the US is just a money problem. The cost keeps going up, and we have to find better ways to do that. And so when I look at how AI is applied to those 3 things, I think we've found that it can definitely help some on the process issues, and we can talk about some of those. I think in the long run, it has the chance to really change the economics. But in order to do that, there's going to have to be massive changes in workflow. And we all know that's very disruptive and hard to do. And on the people side, I think the jury's still out on, is it going to help us solve some of those people shortages? I think it will, but, I don't know that there's a really good way for us to prognosticate that yet.
Yeah.
I think we see the exact same problems in Canada, actually, Dr. Loomis. And in looking at that report from Digital Health Canada, they were citing the exact same issues as well. And it's also quite interesting to see the variability between how they're approaching all these things. So it's really hard to kind of predict where everything's going to end up. And you're right, we don't know for sure if any of these tools are going to hugely impact or help us with that administrative burden, or help with the shortage or anything like that. We don't know for sure, but we do know there is definite utility here that needs to be explored for sure.
Mm-hmm.
Yeah, and I would say that the one place where we do know that it's helping a lot is in the sort of ambient scribing. And again, I don't know how much it's been rolled out in Canada. In the US, I would say it has gone from being a little bit to a fairly substantial number of providers now using it. And for those providers, we have pretty good evidence. It doesn't really reduce the time spent as much as you might think, at least the times in the exam room, but it definitely is cutting down on what we call pajama time. All that time that you spend in the electronic health record at home, trying to catch up and doing all your documentation. And what we really know is it cuts burnout rates for providers substantially in a very short amount of time. And so within 30 days, you can see a major decrease in burnout rate after you've implemented one of these tools. And so while they haven't realized all of what we expected in terms of the time savings, definitely in terms of the amount of sort of administrative load that they're removing from providers and allowing providers to feel like they can just talk to patients again and not be a slave to the keyboard or the screen. Yeah. I think that, in that regard, they have made a huge impact.
Yeah, and interestingly enough, in Canada, we do have the launch of an AI scribe program for exactly that reason, to take the burden off of practitioners. I believe it's 10,000 licenses will be given out for free for the first year. So yeah, there is a commitment in Canada as well to the scribes, for sure.
Yeah. Such interesting points and data that you bring up too, Glenn, right? The idea, I think we will, as we go through the conversation, we will talk about how to try to measure improvements and success, right? But it's really interesting to hear your perspective on the increase or the decrease in burnout within 30 days is such a major benefit, even if we're not necessarily seeing the number of hours reduce. So we really do have to pay attention to multiple factors there. And I also appreciate both of your perspectives. Canada and the US, while being so close and generally being such lovely neighbors, have very different healthcare systems, and lots of criticism on both sides. Neither of them work perfectly, but there's obviously a lot of parallel in what's happening today from both of your perspectives. So it'll be interesting to hear where we converge and diverge as we go through the conversation. And certainly feel free to bring up, Jaspreet, if you want to give specific Canadian context, feel free to, and likewise for Dr. Loomis. So we've already actually covered a lot of ground. I want to bring us back to specifically the doctor's role, and I want to talk about inefficiencies, or where, again, starting with Dr. Loomis, where do you see the biggest pain points today when we start to look at solutions? What are we trying to actually solve?
Yeah, I think the biggest pain points, when doctors talk to me, are really around documentation Also around, I think, one thing that people don't really, I think, give enough credit to is doctors are no different in a lot of ways than electricians or plumbers or other people, right? We have our time to sell, and that's it. And unfortunately, that has been very difficult to scale, right? And so when you see productivity improvements in a lot of other areas of the economy, in medicine, whether it's nurses or doctors or medical assistants, we still do things very much the same way we did things maybe thousands of years ago, actually. And so it's been very difficult to figure out how to scale what we do. And I think we're on the verge now with agentic AI of actually being able to scale some of the things that providers do, which will be a big deal. I mean, and that's obviously what I'm working on and what I care about. And so, but I think that continues to be a big problem. And then this problem of sort of administrative burden, right? And it goes in two ways. I think there's an efficiency and an effectiveness portion of it. The efficiency portion of it is I have all this paperwork. I'm tied to the screen all the time. I don't feel like I can have that interaction with my patient the way I want to because I'm always looking over. And if you're not a great typist, like I'm not, sometimes trying to type and talk at the same time doesn't really work. So there's an efficiency, big efficiency piece there. But there's also an effectiveness piece of this administrative burden. And that effectiveness piece is, medical knowledge is doubling every 73 days, I think they said last year. And so how do I keep up with everything that I need to know as a primary care doc, while and trying to keep my patients safe and give them the best care, right? There's this huge administrative overhang that nobody thinks about, which is I got to try to keep up. And that is a very difficult thing. And we know most providers are somewhere between 2 and 10 years behind on sort of medical knowledge. We all know the most knowledge we ever knew the day we walk out of medical school, and it sort of tails off after that, right? And even then, we know we only knew 5 to 10% of the total medical knowledge at that point, right? And so, how do we keep up? And so that, to me, this whole administrative nightmare from a physician's point of view of how do I keep up both efficiency-wise and effectiveness-wise?
Really, really interesting points in your answer. Despite your point that in many ways the industry has not evolved from what it may have been even 1,000 years ago, I do like your parallel between doctors being notoriously terrible with writing to your version is just typing. So just thought I'd highlight that. But yeah, some really key, the administrative side that keeping up with knowledge or keeping really, really clearly described. Jaspreet, from your perspective, so you're coming from more of the pharmacy side, and obviously from the Canadian perspective. So add a little bit from your perspective.
Well, I'd say a lot of it is similar. And I think scalability, even if you read the Digital Health Canada report, it is an issue there. It's very similar in Canada in terms of the problems that pharmacists are experiencing. And I would add, so in scalability is an issue, but the other thing that's uniquely happening, and it's happening in the States as well, is the expanded scope. So things are shifting all the time in pharmacy. And we now do more than we ever have in Canada in pharmacy, and it just continues to expand. So staying on top of information, like Dr. Loomis said, is imperative, but it is getting impossible almost with expanded scope and staying on top of every single service that you're offering, for sure. So there's a lot of similarities there, and scalability and also considering expanded scope is critical as well.
Yeah.
Yeah, I think the exciting thing... Oh, sorry.
Go ahead.
I think the exciting thing about AI in medicine is that that's really what AI is good at, right? AI is good at facts and figures. It's not very good at wisdom yet, and it's not really very good at maybe ethics yet, but it's really good at facts and figures. And so the ability to upskill providers, to give them the the latest, greatest at the point of care. That's what it's really good at. And now with agentic AI, it's actually also pretty good at doing some of the tasks that providers previously had to do themselves, right? Because, for example, at our company, we've taught now an agent to ask all the questions the same way I would ask a question. So it can interview the patient ahead of time, take all of that down, parse it all into a note, and have, before you ever walk into the office, the doctor ahead of time can have everything in it, in a note format, and look at it and in 30 seconds know everything that it would have taken them 10 or 15 or 20 minutes to extract from you. Now that's pretty amazing from the ability to actually scale providers, right? And the same thing I'm sure for pharmacy is, as your scope grows, sometimes I know our nurse practitioners and PAs feel a little uncomfortable with the amount of scope that they're given sometimes. Well, now I can actually feed them, here's the differential diagnosis for that patient in a sort of stepwise order, and here's a potential treatment plan for that patient. Again, it's all in your hands as the doctor to do it or not do it, but I've given you now, it's kind of like, the way I look at it is the history portion is kind of like having a PA or a nurse practitioner or a medical student or a resident working with you, right? That they're taking that ahead of time. Now I can just look at it, diagnose the patient, and be on to my next thing. The diagnosis and treatment part is like having an expert clinician in your corner, right? Who is giving you, don't forget about this. Don't forget that one little diagnosis that's at the bottom of the list, but you ought to at least have it in the back of your head. Don't forget about the latest, greatest treatment for this diagnosis that you may not have heard of yet, but here it is right at the top of the list, right? And so now as a provider, where I sometimes feel very lonely in the exam room, right? Like it's just me and the patient and I've got the weight of the world on my shoulders. Now I feel like I've got some expertise there helping me out to make sure I don't miss things, make sure I do the latest, greatest, and best for the patient. And so from both an efficiency and effectiveness point of view, I think AI has the chance to really give us a leg up. No matter who you are, no matter what your specialty is, it has a chance to give you, sort of that lift that we all feel like we need. And that, I think, is really going to help from the burnout perspective, but also from the money and process perspective, because now we can tee up information at the point of care. We can reduce the amount of time the doctor has to spend extracting information and have them focus on the things we're really good at, which are coaching and diagnosis and treatment planning and those kind of things. And, I think AI has the potential to be a real game changer if we can get through some of the workflow changes that are going to be necessary to do it, which we all know healthcare is very it's very difficult. Workflow changes are something none of us love. So, we'll see how that goes.
Yeah. I mean, you've teed us up really nicely to understand the promise that AI can bring specifically to the field, specifically to the role. You've given us a vision of how AI and the clinician or the human can work collaboratively and really support one another with each other's strengths, right? So filling in some of those pain points that a doctor, for example, would typically face in their role, but still letting them positioning the doctor really to excel in those really human aspects that AI cannot do for us, at least not today. And we won't talk about, I don't think we'll get to whether it will in the future. But, there are a lot of challenges and barriers, not just in healthcare, but particularly in healthcare, particularly in highly regulated environments, particularly in places where you're going to hit more bureaucracy. We can, one of the things we can look at is tech solutions from the past, right? Both successes and challenges that we face. So Jaspreet, I'm going to kind of tee you up to maybe look at whether it's electronic health records rollouts or some of those aspects from the past that we've seen both successes and failures in.
So Dr. Loomis, can you discuss in which ways past technology solutions like EHRs, for example, impacted clinical workflows and efficiency, and how would you avoid those same mistakes at Query Health with AI implementation?
Yeah, that's a great question, because we we made a lot of mistakes, I think, in the way we did electronic health records. Over the years, I've been fairly critical of some of that. And I think part of it is we didn't have enough clinicians involved in how we set up the workflows, in how we set up the user experience, the user interface. And we ended up with something that looked great if you were a button pusher, but if you're the person on the front end trying to integrate that into a workflow, it just didn't really work. And most of it had to do with the way data flowed in and out of the machine, if you will, right? The data input was very difficult for us as providers, and the data output sometimes was hard. It was very hard to get to the information that you were trying to get to that you knew was in there, but was difficult to get out. I think the great thing about what we're doing at Query Health, but also I think uniquely in all of generative AI, is the data input and extraction pieces that have caused us so much trouble are actually fairly easily solved with generative AI. And so, for example, we can use a voice interface because we don't need to sit there and type anymore. We can use text interface if you want. But honestly, what we're using is all voice now because we think patients will be able to talk freely. And the voice extraction now is so good. It's interesting that even if you make a mistake in what you say, the AI actually understands what you mean. So we will see in the transcript you saying a word that's not correct or, and it'll transcribe it appropriately. But then when you see in the output, it'll actually put in what you meant and not what you actually said. And so it's very interesting how that's going. Also, one of the things that we're building into our product is, for example, we bring in all of your information from the Health Information Exchange. So in the background, our agent knows all about you before it starts to have a conversation with you. But I, as a doctor, I now can ask, when was their last mammogram? And it will just come out, right? The Gen AI can look through the whole thing in a second and bring it out to me. Or, what's the best treatment for hypertension in this particular patient? And boom, it shows up, right? Because it can integrate all of that stuff in, milliseconds. And so I think, again, that we have the chance now to use AI as what I would call a presentation layer over top of EHRs. And I think in the long run, EHRs are going to become more of a transactional layer because nobody wants to rebuild e-prescribing or e-ordering or, the databases that are there, that kind of thing. So I think in the long run, you're going to see a lot of AI on the top because it makes that data interchange so much easier. And you're going to see probably the EHRs staying as more of a transactional layer. We'll see if it plays out that way, but that's what I sort of see in the future as I'm looking at the landscape.
Yeah, and I'd say in pharmacy, just interestingly enough, our pharmacy management systems also, they were probably not built by clinicians. And so we've had challenges with our pharmacy management systems forever. And similarly, I think AI is the solution definitely there. But one of the things you said actually really prompted a question in my mind because I've read about this and I don't know if it's actually the truth. With the AI, the scribes and all of that, impacting documentation so much and helping with, that pajama time, that decreasing that. Was there a training component to it? I had read that, actually doctors and clinicians that were using it had to go through a training component to actually be able to use these tools properly.
I think when they first started, that was true. I will say that right now, ours is very good out of the box. And it doesn't matter, even if you have an accent, even if you have, maybe some odd ways of speaking. It does a very good job right out of the gate. And we started with English. We just added Spanish because obviously we have a large Spanish speaking population in the US. And again, that didn't take very much doing because the AI is really good at the translation and it's even really good at the medical translation. And so while we've had to do a lot of QA on the back end to make sure that it's doing it correctly, we find that the transcription, the translation, the fidelity of those things is so good now, that is definitely not the problem. Where we've had to do a lot of teaching is you have to actually teach the agent how to think. And the way you do that is through prompting. And this is going to be the interesting thing going forward is I don't think, knowing what we know now after we've built our agent, I don't think prompting is going to be, they talk about prompt engineers, but I don't think prompting is going to be the area of engineering. To be honest, you have to have a subject matter expert to create the prompts, because the prompts have to teach the LLM how to think about a problem in order to get the answer that you want. And the only way you can do that is if you have great subject matter expertise, because one little word change can completely throw the whole thing out of whack. And so I think you're going to see that we need a lot of doctors, nurses, pharmacists, etc., to help us write the prompts for the systems that they're using, because otherwise we're going to end up in the same problem we had with the HRs, right? We're going to end up with an engineer writing a prompt that has nothing to do with how we actually do our job. And so we've taken the task that all of our prompting is being written by physicians and nurse practitioners and PAs, because they're the ones who know their job and know how you have to think about a problem in order to get the right output. So it's a fascinating thing. It's very different than writing software. I will tell you, creating an agent is like backwards of how you write software. It's been fascinating from me. I'm a teacher at heart, and so it's very much like teaching residents or teaching medical students. You do it in a different way, but it's the same idea, which is how do you form the knowledge base and the sort of mental structure for the agent to then get to the right place that it needs to get to. And it's really super interesting process.
So really, really interesting points there. Thank you for that. Thank you for that answer. A lot of what you get at is in. So a couple of things. I have heard and experienced that traditional software engineers may not be the best designers for AI agents, and I think for people listening, that actually is promising, right? It is an area that you really can approach fresh and new, and you probably should. I've heard the parallel of the training being teaching, both compared to teaching children and compared to teaching graduate students. So a lot of interesting pieces there, but a lot of what you talk about is in the design aspects, right? And it is almost, so you talk about maybe both with query and with electronic health records not being designed for their users initially, and learning from that. The idea of requiring co-design in there. So really having those subject matter experts responsible for, in your specific case, prompting, but also the usability, right? Jaspreet was kind of saying there was a point in time where that training was a major aspect of it. Glenn, you're saying today maybe not the case, or maybe we've gotten to the point where if design is good enough, if there's enough, if the technology is good enough at being able to use your voice, at being able to translate for you, being able to use those intuitive things that we typically already know how to use, maybe that training aspect can actually be reduced. So I think we will pick up on the training piece. I think we will pick up on the design piece. But I also want to take this as one example of AI being used today effectively, and just round out other aspects or other examples that you're seeing AI in practice in healthcare today. Before we look at, Glenn, you talked about it as a future. I see this conversation as a very near future, and I think before we end the conversation, maybe we'll look further out. So today and very near future uses in healthcare that either of you would like to share, and I don't know who wants to start.
Yeah, sure. There's a lot of great applications. Some are not in the generative AI space; they're more in the machine learning space. So you see, I think radiology is a great example. It is just going very quickly to where it's going to be very difficult to get the type of excellence in reading radiology films without using AI. I think it's going that way very, very quickly. I think lab will eventually go that same direction because, again, machine learning is getting a lot better and is able to read patterns. We'll see whether Gen AI will have a part to play in that or not. I think the jury is a little bit still out on that. Its ability to read images and things is still a little bit iffy. But yeah, I think there are a ton of great applications of AI all over healthcare, whether that's, diagnostics. You see really interesting new things like the ability to tell whether you're depressed based on not what you're saying, but actually the inflections in your voice that you and I can't even hear. But the AI has determined through listening to thousands and thousands of people that this is what depression sounds like. And so things like that, it can also, diagnose things like ADHD, and it can diagnose things like anxiety. And, so really super interesting things that are out there. Also things like reading eye exams remotely, right? Through using AI. That's something where now, I can, in my office, take a camera, put it up to the patient's eye. It can, in a second, read the back of your eye and say, yes, they have, diabetes changes, or no, they don't. That's just amazing stuff. And there's just more and more of that coming, right? It's all around us. And it's going to make a very different world over the next, say, 5 to 10 years.
Yeah. Wild and exciting and really important examples. Jaspreet, any from your point of view?
Well, on the pharmacy side, like Dr. Loomis has spoken to, like the clinical aspects, and those would be definitely true for pharmacy as well. But pharmacies being small businesses, I think that a lot of the utility actually comes from the administrative back office support that they can offer as well. And I think sometimes in healthcare, we just jump to the clinical tools and just kind of focus on those. But I think there's a ton of utility for healthcare providers who aren't working in hospital necessarily, that actually own businesses, to actually support their business as well. All the back end office work, all the appointment scheduling, phones, all of this kind of stuff is very disruptive to workflow. So it is definitely part of the solution. So I see a ton of opportunity there as well. And when it comes to the tools that are being used right now, I think a lot of people are playing in the field and trying to figure out what to do. I think the lack of regulations kind of makes it difficult, but definitely we're seeing a lot of success in the hospitals with, the 8 hospitals that were in that report doing unique things in this space.
Yeah, I couldn't agree more with that, especially on the administrative side. There's just so much being done in that space because it's not as regulated, because there's less risk. And so things like coding and things like answering phones and outreach to patients and, things like that are exploding. And I think they're going to be very helpful to all of us, again, both from a quality perspective and from an efficiency perspective.
Yeah. You've both kind of touched on, a few things there that I want to pick up. One is regulation, so barriers including regulation. Another one that I might pause on just before we get to that, we talked earlier about measurements, measuring. And Glenn, in your chapter in the book, you do talk about measurements, actual AI improvements in patient outcomes. Can you speak a little bit to that, to what that actually has looked like in measurable terms?
Yeah, again, I always look at the world in terms of efficiency and effectiveness. And so I think when you look at whether it's looking at quality measures, one of the cool things about AI actually is it can actually sort of read through all of that text that is so heavily in all of medicine and pull out things and maybe find that, oh, wow, they're doing a lot better on quality measures than we thought they were. They just didn't document them in the right box, right? And so I think it's going to be very helpful in finding out how we truly are doing from a quality perspective. And then on an efficiency point of view, we can easily measure things like, time and number of visits and those type of things. And I think you're going to see, a lot of that as sort of the basis for how we measure things. But then there's sort of the people part of it, and I don't want to forget about that, right? And I think there's three things there that I want to focus on, which are this idea of burnout, which we've already talked about, and we can see a dramatic reduction in using certain tools. But then there's also patient satisfaction. We need to make sure that whatever we're doing, if it's touching patients, that they come back to us and say, hey, that was okay, right? Because if they come back and say, wow, I really hated that, then we're doing the same thing to them that the AHR companies did to us as providers for a long time, right? And then the third thing is just clinician satisfaction also, right? We need to make sure that, again, whatever we're doing isn't overburdening them, that it is giving them tools that they actually enjoy using.
Yeah, really, really important points, and I appreciate you bringing back the human aspect, the satisfaction, right? Like really trying to think about how do we measure the potentially more qualitative aspects. In the book, so one example you mentioned in the book is cardiac AI detecting, saying that it can detect conditions 384 days earlier than standard care, that there's a 30% reduction in sepsis-related mortality after implementing predictive tools, a 20% reduction in readmission rates for high-risk patients using predictive analytics, a 25% reduction in hospital admissions for high-risk patients using AI-powered wearables, a lot of really, really important stats that I'm sure from a hospital perspective, I'm sure from budgets we're really looking at. I am really interested in all of these other human measurement aspects that we might be missing, right? That I think you are aware of and that you are pointing out, but that they may not fit the typical quantitative measurements. And Jaspreet, feel free to add from your perspective if there are coming both from Canada and from pharmacy, what are people measuring? Where are we maybe missing important measurements?
Yeah, I'll say in pharmacy, I think we're kind of in the infancy in Canada, unfortunately. I see so much work happening in medicine, but not as much in pharmacy. And I think the key, though, I think in the ROI analysis is actually figuring out, is it solving the problem a true problem? I think sometimes what we're reading and hearing about is that it's a top-down type of solution where, the people at the top are just kind of driving the innovation, and it really isn't something that the clinicians actually need. Where if you use a bottom-up approach, where the clinicians are actually speaking to what they need, I think you can do a lot more effective ROI analysis on that versus, the other approach. So I think, the key to figuring out what to measure is actually working with the individual clinicians again. So it's that co-creation, I think, is so critical. Again, we're in our infancy in pharmacy. I haven't really seen too much. People are measuring things like just workflow related kind of stuff. How much time did you save? Those types of simplistic measures are really kind of the focuses right now as well in Canada.
Yeah. Okay. Thank you. So I feel like in terms of just a bit of a transition in our conversation, I feel like the promise of AI is real here, and some of the implementation today is proving that, but the path is not smooth, as we can see. Right, there are certainly barriers and challenges in front of us. Some of them are systemic, some of them are regulatory, some of them are organizational, some of them are the people problems, the process problems, the budget problems, those things that Glenn brought up right at the beginning. Let's talk through some of those in a little bit more detail. Maybe some that haven't come up so far that are, even just read the difference between the top down and bottom up, right? The bottom up, that grassroots approach, it really gets the right voices at the table. It typically gets buy-in compared to top down. It also depends on the company size. It depends on a lot of factors whether it will actually work. The top down is what a lot of people are going to be facing in healthcare, right? There isn't necessarily that opportunity for that bottom-up innovation in as many ways. Now, you feel free to disagree with me, but again, just looking at highly regulated, environments, looking at that aspect. So So let's dig in just a little bit more to those challenges and whether we have good solutions for them today, right? Is a bottom-up solution the right solution? I think many of us at this table are going to agree that co-creation in the design aspect is really important, and I think we probably have a lot of ideas on the design aspect. But what are those kind of pressing concerns that we can't control from your perspectives?
Yeah, it's a good question. I think, honestly, we probably have to do a little bit of both, right? Because if you really look at the people who, and I was one of those people for a long time, so, like the people who are implementing things sort of top down, they're doing it because they're looking at things from an economic perspective, right? Well, if I could get that 30% reduction in sepsis and readmissions, I could save the system a ton of money, right? And so they're looking at that. And so they're going to be looking at implementing things in that regard. If you look at it from the bottom up, we're always looking at how is it going to affect the people in the process, right? And so I go back to my 3 pieces from the beginning, it always impacts all 3. And so we need that bottom up to say, hey, these are the people and processes that are really problematic right now. We've been hearing, on the burnout side for a long time, you can't ask me to see more patients and continue to do all these administrative trivia, pieces and put all this data in the computer. There's not enough time in a day, right? But from the top down, they're trying to look at, well, I need all that data so that I can make better decisions, right? And so we need us all to come together. I think part of my career has always been, I speak both business and doctor, and a lot of times they're saying the same thing, but shouting past each other, right? Because they speak a different language, right? Doctors speak about a patient, a diagnosis. They speak in individuals and anecdotes. And, administrators tend to think in terms of populations and disease states and big picture things, right? And so they can be saying the same thing, but miss each other. And I think we're going to get in the same problem from an AI perspective. We're going to have people focused on one thing because they want to save money, and other people focused on well, I want to save this individual life, and we're going to forget to talk about it in the middle and get to which of these things can do a little bit of both. And that's probably the best solutions, right? How do we get to the things that are going to do the greatest good for the greatest number of people, but also have the best effect on the people on the ground? And, that's a difficult conversation to have, but we're going to need to have it.
Yeah, really well answered. Yeah, Jaspreet.
Yeah, I was just going to say that, like the top-down approach, we've seen it so much in healthcare, and that's why we have the challenges we actually do today. And it doesn't even it's not even limited to an individual physician, when you even expand it to, speaking to other clinicians, right? Where right now, Dr. Loomis is very much focused on his work, and I'm focused on my work as pharmacist and physician, but really co-creation. And if we want to fix the problems in the healthcare system, not only should co-creation involve developers and that specific healthcare provider, but also a more holistic approach to healthcare overall. So we're not dealing with the same issues we've been dealing with forever, like interoperability. How do we connect with other clinicians? I think a lot of these issues can actually be solved with AI and through co-creation.
Agree. Teams win, right?
Well, I really did feel like, Glenn's example earlier, a lot of what they're doing at Query Health and a lot of the potential that generative AI in particular has is connecting all of those different people, right? I'll take the the patient perspective here, and it is really challenging from my side, and that everybody doesn't have the same history, that I'm answering the same things, that people are bringing in, somebody down the line is saying, well, have you thought about this? And I maybe have to go back to that person and ask, have we thought, right? There's a lot there that isn't being sort of connected, that history isn't being shared, that people aren't having that sort of holistic input. And I feel like Glenn really did give us a vision of how AI can offer so many solutions from in that for that specific problem. Glenn, I don't know if you want to speak to that.
Yeah, wouldn't it be great if you as a patient were always empowered, you always had all of your information in the palm of your hand at all times that you could show to whatever provider, whatever emergency room, whatever pharmacy, to say, no, these are my meds, these are my allergies. Like, I don't know what's in your box there, but these are what I actually have. And we need to make sure they're all synced up together. And that we actually are treating the patient with the things that they have. Because I know, and I'm sure it's the same in pharmacy, so often patient shows up and they're like, well, what medicines are you taking? I don't really know. Are you allergic to anything? Well, I am, but I don't really know what it is. Well, what health problems do you have? Well, the doctor told, and it's very nebulous. And so as a provider, you're constantly trying to sort through that morass, and try to figure out what the reality is. Whereas with something like Query Health, the patient can always have it right there in the palm of their hand and show you, like, hey, this is me from a medical doppelganger perspective, right? And you need to you need to be able to interact with that, and for me as a provider, I would love that. And also I'd love it as the son of elderly parents who, sometimes I know the story that they're giving their new provider that they just went to. I'm like, boy, I hope they remember to tell them everything, because, otherwise they're going to get faulty treatment, right? Garbage in, garbage out, right? And so, we need to get to a world where things are more connected and we're all interacting with each other and with the patients in a way that is for the good of all of us, right? I mean, that's the key. And is AI the solution to that? I don't know, but I think it has a chance to make a real difference for both us as providers and for our patients. And so, I hope that regulation doesn't get in the way and stymie that. We need enough regulation to sort of protect patients, but we also right now are in a very formative stage, right? And we need to encourage rather than try to stamp out at the moment, right? We need to encourage it and encourage this flame to grow a little bit. And so, hopefully our partners in the government will take that sort of supportive approach rather than a punitive one, and one where we can allow some of these things to grow and allow AI to perhaps give us what we think it can give us, which is that ability to upskill people, that ability to make people a bit more efficient, and the ability to maybe connect us in a better way than we've been able to do up till now. There are so many walled gardens in medicine, at least in the US, right? We have every health system has their EHR, and never the two shall talk to each other. And, and we need less of that and more patient-focused information so that we can all be on the same page, because it hurts patients when we're not on the same page. Sorry, I'll get off my soapbox now.
No, that was an excellent answer. So we are going to we do have a session on responsible and ethical AI where we talk a little bit more on regulatory. So we won't go too far down that today. There is a real tension between innovation and regulation, right? And if regulation is done well, it should put in just the guardrails that we need to be able to smoothly and quickly innovate. But regulation is lagging, and regulation can hurt innovation. So I don't think we'll get into the specifics on what's required from a technical standpoint or a regulatory standpoint today, as much as just understand that it is one of those barriers and there is a tension there. What I do want to, if we have a couple more questions left, what I want to focus on is, we have highlighted barriers that exist. I want to shift into the conversation about how to actually make AI work safely, ethically, sustainably, in real care settings. And one aspect that we do have control over is the leadership piece. So what does AI leadership look like inside healthcare organizations, from personal experience, from what you've seen for success factors, for what you've read in the research?
Yeah, so I would say leadership is extremely important. It's extremely important that we get all of our providers to one, learn about AI. I find that there's so much fear right now. There's a lot of fear about I'm going to lose my job, way more than is necessary, because I don't think that's coming anytime in the near future, to be honest. I think AI is going to help you in your job and make you better in your job, but I don't think that we need to be worried about losing jobs at the moment. And number two, I think that there's just a lot of fear about things that might happen in the future that we don't see at the moment, right? The sort of the fear of Terminator or, whatever. So I think we need to have a lot more education and get our providers more involved in, how it's being made, how it's being developed, how it's being rolled out, how it's being selected by your health system or by your practice or whatever. We need to maintain a leadership role, and it's a very complicated thing. And so educate yourself just the same way you would on any other medical technique or medical issue. You need to learn the basics of AI because it's here to stay, and it's going to dominate how we practice for the long term, most likely. And so you really need to educate yourself as a clinician.
Yeah, and I'll say I think leadership being involved in every aspect of AI implementation is actually quite critical, because even if you read the report from Digital Health Canada, one of the reasons why those hospitals were successful was because they had leadership involved at every point, and that kept them quite agile and able to make decisions quite swiftly and quickly. And the other thing in terms of leadership is having people represented from various departments and not just focusing on silos. So you have the top leaders, but you also have people from other departments, so everybody can play a supportive role in development. So for sure, I think leadership is critical, but also involving other departments and people from those, I think, is critical as well.
Agree.
Thank you both for your perspectives on that. Coming from a digital design background with students who are practicing design thinking every day, the idea of or the necessity of co-designing, I really do believe is central. It's come up several times in this conversation. This might have been the first time that we have talked about the fear of job loss as a real barrier across industries, but also definitely in healthcare. Dr. Loomis, at the beginning of his chapter 16 in our book, does have a nice quote, which you'll have heard iterations of this before, I think. So it says, artificial intelligence will not replace doctors, but doctors who use artificial intelligence will replace those who don't. And it used to be, a couple of years ago, it was something that we said and we thought was probably true. Today, it's something that we know is true. It's well proven. And so I really do think that there is a way to design without job loss being central, but with an AI human collaboration that, as Glenn gave us a vision earlier, really does support the individual, in this case in healthcare, the physician's role, with the way that AI can support it the best. Great examples of how it actually empowers the patient going across the healthcare system. And really, a lot of that top-down pressure is budgets, is metrics, is reporting. And I believe that these systems really do feed back those necessary measures as well, for it to be supported across the board, not to pretend that there aren't barriers that we still have to overcome, but there is really a lot of promise there. As a closing question, not because the conversation's over, but because this segment will be for today, I want to ask about, for both of you, what excites you most in healthcare looking into the future? So looking at what's next, and it can be the near future.
Yeah, I think for me, I think AI has the potential to democratize medical information to all people in all geographies from all socioeconomic standpoints in a way that nothing else has. So you can say, oh, the internet has, but the internet is very, it gives you information at a very general level. AI has the potential, especially if we can do like we're doing at Query Health, where you can get information that's highly tailored to your actual medical history. It really has the potential to give you something that arms you when you go in and talk to your provider, or you go into the emergency room or whatever. You can have that second opinion that already is laid out for you. Hey, you should think about these things, right? So that you can have a conversation with your doctor that puts you a little bit more on the level. Because I think, although I am a doctor and I've had a lot of these conversations over time, I think that there's a problem with the imbalance of information in a lot of those conversations. And so they come to me as the oracle of all things medicine, right? And that's great. And I'm fine to do that. That was my role for a long time. But I think the role is going to change now. And it can be more of a conversation where you say, hey, the AI says this, that, something else. And I say, well, your case is a little bit different than that, and here's why. And you can actually understand the nuance a little bit more, and you'll understand a lot more about your health and about how you can be empowered to improve your health and your healthcare. So I think it has the potential to dramatically change how we as humans are empowered to work on our health and on our healthcare.
Yeah, and I'll add to that. Like, I agree with everything you said. I think that personal empowerment piece is so critical, because I was literally seeing clinicians lose their light. Like, they just were losing the joy in healthcare. And I think if they were able to find the time back, to live their life as well as support patients, they would find that joy in healthcare again. So I think, in addition to everything Dr. Loomis said, I think that's what excites me, is that personal empowerment and the ability to kind of live your life on your own terms, and you live your dreams out as well, right? I think there's a lot of potential that AI offers. People who went into healthcare knew there was documentation, knew there was administrative burden. They probably didn't know there was this much and that it would take this much time. And so, like in the chapter, I also talk about, the ability of clinicians to maybe make it home for dinner with their children. I think those kind of aspects are actually quite critical, because it is a quality of life question sometimes as well.
I love that. If I had to say what was my second, it would be exactly that. So agree with you entirely.
Yeah, beautiful answer. And Jaspreet, thank you for referencing your chapter as well, which does really, and of everything that you cover, I think it does really focus on work-life balance and quality of life, and how AI has given that back to you.
Yeah, absolutely. That's definitely a part of my personal journey, has been that AI literally changed my life. And I am super excited to see the potential in healthcare, not only, again, not just personal empowerment, but also the potential of healthcare to solve so many different problems we have right now.
Yeah. So just before I close this out, Jaspreet, do you want to talk a little bit about, again, closing us on AI in healthcare, AI tools in particular today, and maybe look a little bit about each of the different perspectives, from a clinician to a healthcare leader to an AI developer and so on?
Yep. Sorry, just give me a second. We're going to have to edit that. I'm just going to find it. You had it highlighted for me a second ago, but okay. So AI isn't replacing clinicians, right? It's reminding them that why they became one in the first place, which is what I kind of alluded to. The challenge now is really the design aspect of the tools that give back the time, clarity, and the connection. So if you're a clinician, ask yourself whether the AI tools in your workflow are actually reducing your time and cognitive load, or just adding more clicks and complexity. If a tool isn't really making your day better, speak up. Your feedback really does matter to these organizations you're working for. They really do need to hear when tools aren't working, so they can fix them or abandon them, really. So if you're a healthcare leader, whether you're a chief medical officer, hospital administrator, or department head, build your champions and feedback loops. That is so critical, having a champion at every organization. Before you do deployment, don't just pay for AI tools that are out there and push them out. Co-create, which is what we've been talking about. Co-create them with your clinical teams from day one. Start with real problems that your clinicians actually have.
Couldn't have said it better myself.
Yeah, Jaspreet, really well put. Dr. Loomis, was there anything you wanted to share for our audience today that we just haven't touched on yet?
I don't think so. I think you've led us through this very well. I just want to take this opportunity to say thank you, and I enjoyed this conversation just as much as writing the chapter in the book. So hopefully people will read the book. But if not, hopefully we gave them something to think about today.
Absolutely. And I want to thank you both for taking the time today to share your expertise with everybody listening. This has been another feature of the AI Revolution Learning Series on AI and healthcare. And today we've been joined by Dr. Glenn Loomis, founder of Query Health, and our in-house Canadian expert, Jaspreet Chager. I've been your host today, Carrie Purcell, featuring more of our great authors and more content from the AI Revolution. Thanks, everyone.